Welcome to the All Things Physical Therapy podcast with your host, DPT Steph, your doctor of physical therapy, talking all things PT while bridging the gap between students and the clinician they want to be with an interdisciplinary approach. Thank you for tuning in to the All Things Physical Therapy podcast. This is Stephanie, your doctor of physical therapy, otherwise known as DPT Steph. On this episode, we'll be talking with Dr. Katelyn Corridon, a doctor of physical therapy currently working in acute care and the ICU. I'm so excited to have you, Katelyn. To get us started, why don't you give us a little introduction about yourself?
Yeah, awesome. Thanks for having me, Steph. So I got my doctorate from Emory University in Atlanta, Georgia. I still live in Atlanta, and I graduated with my DPT in 2018. I've stayed in Atlanta, and I work for Emory Healthcare at Emory University Hospital in cardiovascular and pulmonary acute care and intensive care, mostly surgical, although with COVID, I have dived back into the medical side, and I love it. After my DPT, I did the Emory Acute Care Residency. So I rotated through 8 different specialty areas across 2 different Emory healthcare hospitals, tons of mentorship, research time, teaching time, just really went crazy for a whole year. And my fiancé and I live in Atlanta with our dog, Sadie, and we're trying to plan a wedding in a pandemic, and it's a good time.
So many exciting things going on. Let's just throw a pandemic in the mix. Why not?
Why not? Why not?
Super, super cool. All right. So let's talk about kind of from the pre-PT school into PT school. Did you always know that you wanted to do acute care? What were your clinical affiliations like or pre-PT experiences like?
No, I didn't know I wanted to be a PT at all through college. I always thought I was going to medical school. I really liked psychology. I had an open mind in general. I knew I wanted to go somewhere in the medical field. At that time, my experience was like all the medical field is a doctor and a nurse. Like that's it. There's no one else in the universe until I dived a little bit more into my allied health coursework in undergrad, ended up getting my bachelor's and my master's in exercise physiology. And through that, I got to have both experience in the sports medicine side, which was awesome. I was a student athletic trainer for the women's field hockey, women's lacrosse, and men's football teams. Obviously, we didn't have a women's football team. So we got lots of sports medicine side, athletic training. There were PTs that were athletic trainers also, and they really mentored me through this whole thing. But my love for athletic training was definitely in the acute injury phase, the on-field stuff, the injury prevention and rehab side, not so much. So I really liked the triaging and medical injury portion. So then the PTs that I was working with helped me get opportunities both in outpatient PT clinic settings, very traditional, but also with cardiac rehab and inpatient physical therapy and cardiac care. And that's really where I fell in love with the heart and older adults even. Although I thought all the way through PT school I was going to do pediatrics. Obviously, I like to keep an open mind, but I have done a little bit of everything from sports medicine all the way through cardiac pre-PT, and then since PT school, really, really fell in love with acute care and intensive care. I had some awesome professors. Both are incredible acute care and ICU clinicians, early mobility specialists, and they were the directors of my residency program. And so they've been awesome to say the least.
Did you have, I'm trying to follow the story because I think there's many things involved. Did you have a acute care affiliation in PT school?
Yes. So all of those examples were from undergrad. That's just how I ended up in PT school at all. And then in PT school itself, the way Emory's program is set up is you do 3 short-term clinical affiliations in between kind of the courses that they correspond to. So the first one is called general medical, but it's all acute care. And then you do a 2-week acute care affiliation. And that is all of the students in my cohort got 2 weeks in acute care at the same time, which is crazy that they managed to put all that together. But I got to do level 1 trauma ICU as my 2 week, and loved it, loved it. And then you do an ortho and a neuro after that. And then for the long terms, it's actually in the middle of our program, and you come back for 2 semesters after of research and schoolwork, and you have to do an acute care long term through that as well. So we set it up as acute care, rehab, so multidisciplinary rehab, and then outpatient community based. So the outpatient community based could be in home health, it could be traditional outpatient. The rehab could be inpatient or outpatient as long as it's a multidisciplinary approach. Like, so some people did children's day rehab. I did inpatient rehab, like adult, very traditional, acute rehab based, and I did it at Johns Hopkins. And then my acute care affiliation was actually at Children's Healthcare of Atlanta, right across the street where I work, in peds acute care, and I fell in love with it. I mean, I still love peds acute care, could still see myself and going back in that direction at some point in my life. Babies are a lot easier to transfer than adults, but I still just really loved the heart, and that took me back to adults and through residency. But yeah, so long story short, I had 2 acute care affiliations and 1 inpatient rehab affiliation.
That's awesome. I mean, there's so much like variety in your experiences as well, which I think is a super, super important take because I mean, you kind of have to take everything that school gives you and consume it all and figure out what is it that you may like or don't like, and then what is it that you truly love. And I know same thing for me. Like I went through 4 affiliations and acute care being my last one. Everything I was like, oh, I enjoy this. Okay, this is okay. I don't hate this, but then when I got to acute care, I was like, "Yes, this is the money right here." I love your journey so far. I think that's awesome. I know one question I get almost all the time in my DMs, and I'm sure you're now on Instagram, you're gonna start getting them too. Why did you choose a residency? So before you answer, I just want to preface this as saying I'm not for or against residencies. I didn't choose one. My answer to people who always slide into my DMs is if you think that there's something that's super super specific that you want to go for, then I think a residency is the right track for you. So whether that's pelvic health or acute care ICU, like whatever, if there's something specific. But if you want to go into it for a certification, there's multiple ways to get a certification. I know there's like the people go in for an OCS or SDS, so you don't have to do a residency for one of those. Completely separate, but also if you like research or want to get into more of a teaching side, then you can also do a residency. So what's your take on all this?
I totally agree with you. And I really think my reason for doing a residency was that I wanted to be good, if not great, at a lot of different things. And I wanted to do it fast. So I didn't necessarily, well, acute care doesn't even have credentials anyway. We don't have a test we can take at the end to get these super fancy 3 letters after our DPT. If somebody's doing acute care residency for that, they're going to be sorely upset when they get to the end and realize that test creation is still probably 3, if not 4 years away. I am very involved in the Academy of Acute Care, so I will keep you posted if that ever comes up. But no, I loved acute care through my affiliations. I loved pediatric acute care. I just felt like there was so much left to learn that I just didn't have a handle on whatsoever, and knew I loved intensive care. And I knew that if I went to get a job anywhere, I would have to take and, pay my dues and take my time and take all these years of experience and probably do continuing education on my own, and you have to put in a ton of work to end up in intensive care. I wanted the fast track, truly, because I knew that's what I loved. I wanted to be, just like my 2 amazing mentors, I wanted to be an early mobility advocate. I wanted to be pushing boundaries. I wanted to get people up that we previously thought were completely unstable to get up. Spoiler alert, we've done that, and we're doing that right now, and that's what I wanted. I kind of fell in love with the other pieces while doing the residency, but I definitely started the residency program wanting to be a really good clinician. And not to say that you can't be a really good clinician, obviously, without doing a residency. There's only 8 acute care residencies in the country. So there's only been about 25 of us go through them. I happen to work with another one of them. She did the Hopkins residency. She's also a fabulous clinician. She leads the CCU team. Latasha Harris is her name. She's amazing, and a great resource for me too. But yeah, that was my motivation to do it. Is I wanted this specialty experience. I wanted tons of mentorship, and I didn't want to have to work on my own time to create that for myself. I wanted somebody else to put it together in a nice neat package for me.
Oh, for
It worked
sure,
out
because
that
it's like
way.
we know from school too, structure is always best, and like we've been students for so long, so I know it's so hard making that transition without having like a formal mentor. And I know that's why I think it depends on totally what you want to go into, because I know I was like, I don't know if I want to do a residency because I think I can find a job that fits like a good mentor category. And I knew I wasn't going to settle until I found a job that really kind of fit the description of what I wanted. So I think if you're somebody who needs like a formal structure, I think residencies are great. And I think if also if you kind of have in your head, like I know what I want in a job and you're willing to wait a little bit longer too, if like you don't get it right away, then I think, there's kind of you can go both ways, and I think that's, like, the great thing about all the options that we have as PTs and, like, settings and jobs that are out there. I mean, granted, we're in a pandemic, so maybe the jobs are more limited right now, so this is
Who
not, like,
knows?
solid advice, but you never know. How long was your residency, and what was it like going from day 1 to finishing it out? So, was it more like every other day was different, or every other month was different?
Yeah, it was a year residency program. It started in August, ended in August, which was great for me because I actually took July boards. I know a lot of people looking into residency programs. For all of you third year DPT students out there, are really anxious about taking April boards, but that was not required by my program. And I feel like a lot of programs will hang in there with you if that's what
Mhm,
you want. But I rotated across Emory University Hospital Midtown and Emory University Hospital for my clinical portion of my residency. And it really was a little bit different every day, but I'd say the majority of the time, I really felt just like a treating clinician. I went to work, I was in my scrubs, and I had my caseload, and I did my job. Also, very similar probably to how you felt as a new grad therapist. You had somebody either on your rotation or assigned to you that was there for you to answer questions with, pick their brain, especially in the first couple months. Like you're just orienting. Like you
mhm.
want to know what the code, the numbers to all the linen closets is, and where do I go to get my badge access. They handled that piece, but then also just like one step further. So I started in orthopedics, which at our hospital system, the very standard knee, hip, spines are handled in a separate hospital. And then the more complex, um, like oncology, knee replacements, end stage renal disease, femur fractures, like the people that kind of have extra complexity, that's where I started with orthopedics. I moved through general medical, wound care, cardiovascular and pulmonary, intensive care, and neuro intensive care in the first hospital. And in that hospital, all of the therapists rotate. So I was just rotating a little bit faster, and then moved to the second hospital where I now have my job. And there, the therapists are assigned. And so they stay in their specialty area all the time. So I got to rotate basically between people that were experts in those specialty areas. So I started back in neuro and neurosurgery, and all of these specialty areas, they keep the ICUs kind of bundled with those. So neurosurge, and then did MICU, SICU, so medical ICU, surgical ICU. That's where our kidney, liver, and pancreas transplants land. Did some oncology and bone marrow transplant with that. Then did, Lord, this is a long list, sorry. Then did more liver, kidney transplant, and then finished where I ended up getting hired, which is cardiovascular and pulmonary in that intensive care system, which is very heavy in our hospital. So they a little bit biased the length for that, kind of compressed the kidney, liver a little bit. So there was like a little bit of fluctuation here and there on not just how long I spent in each rotation, but also who was my mentor. My cardiovascular and pulmonary mentor mostly worked on the floors, so then he set me up with the ICU specialist for the end of that. And I had some fantastic mentorship. And so, like you said, um, anybody can get a great mentor at their job, and that's especially something I would recommend that anybody look for in their job. I mean, there's no way to be a good clinician without learning from the people who have been experts at this. So I got 8 of them across a year. So it was just a little bit faster and just a little bit more broad. But in those mentors, I had a oncology specialist, 2 neuroclinical specialists, so people that really were not just experts from a sense of like career longevity, but also had sat for those advanced exams and had mentored other residents. So the Emory neuro residents also rotate through our acute care system. So, I mean, from the most part, it's very focused on clinical time, mentorship, but you get that time set aside for your mentor to physically go into the room with you, watch you treat, and give you feedback. I mean, for the entire
Yeah,
first year that I practiced, I
that's
at
awesome.
least once a week, if not multiple times a week, had somebody literally watching me do everything I did in that patient session and sit down afterwards and fill out a form and tell me how I did about it, which was horrendous and miserable and so anxiety producing for the first like month, but after that I got
And
over it.
I wanna harp on too, because this also, like, I think talking about the residency is great, and I also wanted to have you on to compare now post-residency, like, your work, I would say, I'm air quoting here, but, like, your work
Yeah.
environment, as a non-resident, I guess, or, like, full-on clinician, and compare it to, like, what I experienced as a clinician in my hospital and what I know, like, I have friends were experiencing in their hospital too, because it's so hard. There's not many acute care therapists on social media, and I don't wanna say like, "Oh, this is acute care," and list, like, all of the units in my hospital and talk about how my hospital runs, because I know it's totally different from even another hospital in New York City, let alone probably your hospital or someone else's
Yes,
hospital across the country.
for sure.
So, I'll start and say kind of how my flow has started, and then I want you to compare yours as well.
Yeah,
So, for
absolutely.
example, um I had, like, a supervisor, my manager, who we had weekly meetings. Whenever I had questions, I'd write them down throughout the week, and we'd meet every single week at a designated time for about 20, 30 minutes, answer any questions I had, and I started on a general medicine floor. Unfortunately, was there for much longer than anticipated because that's where all the COVID patients, started and were kept for the longest period of time, even though our whole hospital became COVID at one point. So I did not rotate, after a usual 3, 4 months and switch my floors, 'cause that's how we typically work. Um, didn't have really any formal mentorship because it's on a general medicine floor, so you kind of should know the basics at that point, and it's, like, more of I wouldn't say simple acute care because they're very elderly, very very sick sometimes, but like, I guess the more textbook gymnastics is not really there compared to, like, a neuro unit, right?
Yeah.
Um, Over the summer, I switched to, more like abdominal surgeries, plastic surgeries, vascular surgeries, and our mentorship, when you change units, you need to get, like, signed off on these patients, even though you might have seen them in a clinical or a prior job. So we have kind of what you described, a supervisor who has some kind of specialty, and they come observe us and talk out the case beforehand to make sure we know what to do, we know about this patient, and then at the end, they'll say, "Okay, you're good to see these on your own now," or, "We need to see a couple more to really get you, like, making sure you got a grip on these kinds of patients." And they try not to rotate if we have, like, 3 or 4 therapists in 1 unit, we try not to rotate all 3 or 4 off the floor at the same time so that there's one more, like, senior person there, so if people have questions, they can rely on them, and so forth. And our ICU is actually kept as, like, almost a completely separate staff, so we don't rotate into the ICU until it's, like, several years that we've been in the hospital, and then maybe if a position opens up, then we can kinda transfer into it. So, super, super different, and I know, like, a hospital size, I still don't know how many beds we have. All I know is we have 2 ginormous towers, and
there's, like, almost 10 floors in each of patient units, so we got a lot.
Yeah, and I practice now in 2 different hospitals, and, like, what you've described kinda is similar to how one of those hospitals run, and then my hospital is just the one that I currently work in, although I've worked at both, it's just totally different. So you're exactly right. So even within one healthcare system, you can have
Right.
a completely different staffing system, completely different ICU system, patient profile. I mean, you can run the gamut no matter what. I will say, like, probably the difference, I think, between residency and just like in job mentorship, which is probably the purpose of a residency, right? Is the quantity and the quality of the mentorship. So the purpose of residency mentorship is not to check the boxes saying that you're a safe and quality clinician and that you will grow as a clinician on your own separate from formal mentoring, right? Like that's the idea for mentorship within a residency program, it is how can we make you an expert in this field in 6 weeks? So how can we make you an expert in medical and surgical intensive care unit in 6 weeks? Even though you've only been a treating clinician for 8 months, I'm going to ask you all the hard questions right now in front of this patient, in front of the MDs. I'm going to force you to present. I'm going to force you to, like, it's really pushing. And I will say I asked for it, like, and if
Yeah.
I had been in a position at the time where I had been uncomfortable with that, I probably could have said, "Hey, Primrose, can we like back this up a little bit?" So I think everybody's program is different, but it really is about pushing you beyond being safe, competent, and able to handle, what's basically thrown at you and go the next level. Like,
Mhm.
how can you be an advocate for our profession or like, because each area has a different system. Primrose is a mentor that I had in the medical and surgical ICU. She rounds daily with the charge nurse and the MDs to advocate for which patient she wants consults on. Like
Yeah.
that's not normal. I feel like it should be. She has set herself up to do that. She created that for herself. So she basically put me in those shoes and said, "Do it." Like the system is set up for you there. You may not know anything yet, but do it anyway. And also just from a quantity standpoint, we had 3 to 4 hours per week set aside for mentorship. And that's because I was not an employee of the hospital. I was an employee of the university. And so productivity wise, mine didn't matter. They weren't
Mhm.
paying me. So even from a logistical standpoint, I felt very protected, felt very safe to ask my questions. That was what my job was set aside to do. And they were essentially volunteers, very encouraged volunteers. But their productivity and their time was protected because if they were in the room with me as the treating clinician, they got the productivity units for it. So we really worked out a system that was safe both for the mentor and the mentee, the resident, so that like everybody could learn and grow and not feel like that overhead pressure of that we all feel now.
Mhm.
That's my like comparison to now. Productivity standards, staff meetings, like just the stuff that has to happen to get your day done. You don't feel like you're pulling away from people's time, which was really nice. Now looking back, I don't think I appreciated it as much in the moment as I do now. Um,
Right. What is your productivity, so we'll touch on that a little bit too. So post-residency, obvious, of course, what is your day-to-day, like, productivity-wise? Because I know typically in an ICU or critical care setting, it's on the lower side that I would say, like, more of an acute setting.
you'd think so. It would be really, really nice if it was.
For us, it is at least.
Yes, we do not change productivity standards depending on the criticalness of your unit at my specific hospital. I think that probably speaks to the criticality, is that even a word, of our patients across the whole hospital. So all of the neurotherapists are also treating in the ICU.
Right.
All of the general medical therapists, not all, most will float into our medical and respiratory ICUs. So everybody's got a little bit of that high level patient on their list. I will see in the cardiovascular side, we do tend to stay in the ICU and then follow some of our patients to the floor. So we are a little bit
Okay.
more ICU heavy on our team, but it's not. I feel like it's not standardized. It depends. That's another thing we could talk about. But yeah, so we bill on we do our productivity on units. We're expected to meet 17 units a day. I can usually do that if I'm seeing between 6 to 7 patients a day, with a handful of evals, usually 2 to 3, because my sessions are longer.
Mhm.
I am generally in the room with my ICU patients at least an hour.
Yeah.
So instead of the gen med floors or anywhere else where even just cardiac surgery floor, I can be in and out of an eval and a treatment session in 15 minutes if I really wanted
Mhm.
to be. Sternal precautions. Can you walk with a walker? Great, go home. But I then go downstairs and I've got a 24-year-old girl who's on ECMO and we're walking, and it takes for an hour to do that. So it's nice to have a little variety, but it definitely is labor intensive and time intensive. But
Yeah, and I
it's
think
nice
the
for
one
units.
exactly, and I think the one thing that I love about acute care, and you might agree or disagree, but the one thing I love is that there's so much variability in patient presentation, even though their charts may look completely identical. So you might think that on paper, you're like, "Oh, I've had this kind of patient before. They're gonna be fine. They're gonna be up. They're gonna be walking." You walk in, and it's like someone who can't even sit up. They're like struggling to breathe, or they're so orthostatic, or I don't even know, like, case manager got the
Yes.
whole functional history wrong, and you're like, "Oh my god, what is going on? I have no idea."
Or they're
Mentally,
just
like,
totally delirious and they
delirious.
usually look
Yes,
great.
exactly, exactly.
You
You're
give
like,
a
"Are they?"
70-year-old woman a little a UTI, next thing you know, she's dependent and can't move at all. Oh, yes, I know. I totally agree. Totally, totally agree. I have been burned so many times thinking, oh, I can just pick up this quick eval at the end of the day on the Friday because
It's
somebody
never
needs to
quick
be
if you
seen.
pick it up at the end of the day thinking it's going to be quick. You have patients who refuse. I know I always write to the team or they're like, "Why isn't this person working with PT?" And I'm like, "Well, they, don't want to for, like, 3 days." And then they're like, "Alright,
Constant
we'll go
pushback.
in, we'll nudge." And then it's like a constant battle between, is PT actually doing their job slash is it the patient?
Yes, yes, and we say some teams there's street cred that you can build, and there's some teams that there's not.
Mhm.
Hospital medicine, I feel like is a team you can't really build street cred with because they have so many residents and they rotate so frequently. So I feel like the next thing I know, I'm learning a new name and a new face. They have no idea who I am. They don't necessarily trust that I did give it like the best try. And yes, I get a reconsult immediately the next day. Like, please come back and see this person. Or, they see my refusal note from the morning, they see my page, and then they say, um, oh, I just told them that they really need to work with you. Can you come back? They're willing to do it now. No, I can't. But I do. I usually do. I'm a soft heart and I will usually just come right back. But if I get refused a second time, then forget it. Yeah, but then there are some teams that I really do build a really strong rapport with. I sit on the heart failure advanced heart therapies board, um, and so it's all of our cardiologists, our surgeons, social work, nursing. I'm the PT representative. I have our OT representative. We, as a team, decide who is appropriate for either consideration for heart transplant or LVAD. And in working with that team, we also follow our post-op patients. And so that's where I bring my concerns of, hey, Mr. So-and-so is getting weaker and he hasn't gotten his heart yet. Has tons of abdominal pain. What can you do to support my efforts? Because all he's seeing is me walking in every day and demanding that he get up, and he's in tons of pain and he doesn't want to, and he's starting to refuse at this point. So that's where I feel like that rapport just really helps, not just with the patients, but also with the team, because they'll walk in and say, hey, Katelyn knows what she's doing. She's never going to ask you to do something that's unsafe. We know you're hurting. We'll do our best to manage that, but you got to keep pushing because otherwise you can't get this heart. It's currently an issue I have right now with a specific patient. So I think the collaboration is really nice. The more I build it, the more I see the benefits of it. And then I get a little frustrated when I can't with other teams because
Yeah.
you just have that high turnover rate in some teams. There's no way to know everybody.
Yeah, and that's true. It's a barrier for sure, and I also wanna touch on how have you managed with patients and discharge, and have you had the unfortunate barrier of you want someone to go to inpatient rehab or you want someone to go home and then or to a SAR and or subacute rehab, and then there's, like, an insurance issue or a physician issue, or they need wound care and the place they wanna go to doesn't provide wound care, or they need antibiotics and so forth. Have you run into these issues, and how have you essentially overcome them?
I run into them daily, I feel like, especially lately with COVID. I mean, a
Yeah.
lot of the SARs and rehabs around us have closed their doors or said you need two negative COVID tests, and they'll find any reason not to take somebody that's borderline or uninsured or, whatever. I have lately been digging into evidence to say, like, okay, what can I do to get someone home and have it be okay? And
Mhm.
we actually had a very robust conversation with some of the social workers on the bad team because their caregiver restrictions are so tight. Um, but it's like, do we really need to have these caregiver restrictions be so tight? Discharge planning is a nightmare for bad patients. And I'm using this example because these are a lot of the patients I work with. They can't go to subacute rehab. They can only go to our inpatient rehab and then home. And if they're
Mm.
not ambulatory at that point, we're asking this caregiver not only to change dressings daily, but also do mobility. Like that's a lot we're asking of these people. But so I'm just trying to be really creative with safe and effective discharge planning. It's like the best way I can put it. And then if I'm really really sure that somebody is not going to be safe to go home and the team really wants them to go home, I absolutely will never change my racks. I will be like,
Yeah.
that patient can leave against my advice. I have run into issues lately where I feel like what the team will sometimes do is show up at the patient's room and say, "Hey, do you want to go to rehab or do you want to go home?" Of course they're going to say they want to go home. Like, who wouldn't want to go home? It's the holidays, it's COVID. Like, of course you want to go home. And so then I have to do a little bit of that back education saying, "Hey, it's not just I want them to go rehab for the fun of it. Like, these are the reasons they're not safe to go home. I need you to advocate to them about that."
Yeah. Yeah, and
So
I think that's
that's
a
something
huge
I've run
thing
into.
too. Right, because it's like, you also have the side of it too where I don't know if it's just like my hospital, like with the social worker or case manager too, but, there's like a business side to it where if you have a readmission and the person goes home after the person goes home, then, like, you can get kind of essentially docked because of insurance and, that kind of profitable side. So they, like, almost push subacute rehab if the patient is truly borderline, but, like, kind of has some family support. So it's like, I don't know if they fully need rehab because they have good support at home. Maybe we can get them home, but then they're like, if they're borderline and have a chance of falling, do we really wanna send them home? So then you have the whole, like, teetering back and forth, and it's like, "Give me just one more PT session. I promise we can, like, we'll do it the next day. We'll do it tomorrow. We'll get better. We'll get stronger. We'll figure it out."
I've definitely done that lately. I think we can all advocate a little bit more for a slightly longer length of stay because there's nowhere to send these people right now.
Yeah.
So I've kind of made the argument like, hey, they'd have to be waiting for SAR for weeks if they're sitting here. Can you give me 2 more days? Can I get them walking just a little bit further? And let me prove that they are safe to go home, and then I do kind of throw that back. I'm like, hey, if they readmit within 30 days, this is hospitalization is not paid for. Um, so let's try to do everything we can to prevent that. And actually, this is a fun little segue. My research group. So I started research through my residency program. It's like pieces we didn't touch on. There's so many things. I did research. I did teaching. I did didactic work. I did all kinds of stuff. But one thing that has really stuck into my clinical life that is fun. I don't get paid for it. It's like literally volunteer labor of love is my research projects. And one that started was looking at the impact 6-click score in ICU for cardiac and cardiac surgery patients. And can we predict where they're going to go?
We use the AMPAC with all of our patients.
Oh, brilliant. It's no
Yeah, and
longer
we have
required
the
because we don't
breakdown of
decode anymore.
right,
Um,
but we have the
so
breakdown of, like, how many visits or how many times the patient should be seen depending on where they score on the AMPAC.
maybe you can come to my hospital and convince people that this is worth doing. But that's what I'm trying to do. So we
Yeah.
did the impact just on eval for a lot of these patients. So that's all the data that we had. And we were looking at, okay, does that eval score tell us enough that we can start predicting discharge. And in 91% of CT surgery patients and in 92% of CCU patients, we can predict whether the patient's going to go to a facility, so not SAR versus acute rehab, that not that nuanced, but a facility versus home. Like,
Wow.
so that first initial PT visit and the cutoff score, which is really what we want to know as clinicians, right? Like, what do you score them and what does it predict? Is about a 15. So if they're scoring 15 and above, odds are they're going to be here long enough and have enough therapy to get to where they're safe to go home. And if they're below that, then odds are they're going to need some sort of rehab, even that
Yeah.
early on. So that's it. I hated research classes in school. Absolutely hated them. It's the only like almost failing class I snaked by in PT school was research methods, and now here I am doing research and continuing it, and I mentor some of the PT students through it. But it's because I thought this was valuable as a clinician. I wanted to know. So now we're spreading the love to the MICU, and we're taking a look at the MICU. And then I've also now started a project on COVID. So
Love
that's
that.
something we're looking at too. So with the research into COVID, this really started as again, just a clinician's curiosity. I had been working with the university at this point for a year with mentoring students through research. And basically they get the experience of being on a research project. They do all the data collection, all of that without having to do like the researcher side and dealing with the IRB and the longevity of the project so that they can graduate and be done with it. Which I really appreciated as a PT student when I had to do this. And again, as Emory's program, we had 2 full semesters after clinicals to come back and do this. So they get to spend basically a year working on this stuff. But yeah, we were finishing up last year's group. That was probably mid-May, early June. And we were thinking, we have more space to add students to my research mentorship group. What other things could we be looking at in this crazy time? Of course, we're going to think about COVID. And we'd already had the experience of looking at ICU level data with the AMPAC group. We had a good understanding of how to get into these patients' charts, and we had created an IRB. We were like, okay, let's go for it. And what we didn't know is the Emory system had actually fast tracked any research that had anything to do with COVID through the IRB system. So we submitted our proposal and we were up and running in, I swear, like 3 weeks, which is unheard of. Usually these things take forever.
Right.
So what we're looking at is um, patients who are diagnosed with COVID end up in the ICU across any of the Emory healthcare hospitals that use the same EMR system, which is 4 of them. And what happens to them while they're there? Do they get PT, OT, or speech? And where do they go? And that's basically what it is. Um, so we're pulling tons of data from charts, anything between um, oxygen levels at admission through discharge, lab values. I mean, we really sat and sifted through tons of literature. My students did, to look at what was relevant, what was coming out. It was all brand new, hot off the press kind of research. And then really taking a step back. Okay, we've seen all of this literature come out saying that carbon dioxide levels are important at knowing what a patient's medical outcome is. Is anybody looking at their functional outcomes? And of course, the answer was no.
Mm.
There were some papers from the Australian groups that were looking at PT utilization, which I think was really important that came out first. Is like, yes, we are important. What do we do when we get in the room? Why do we advocate for therapies using precious PPE, using precious, time in a patient's room, resources of any kind? And I think we were able to hurdle that barrier a little bit. And then now it's like, okay, what impact are we having, if at all? Are these patients just so sick that we're not making any impact at all? I really doubt that. But we could see that. What I'm guessing is what we see is the patients that get physical, occupational, and or speech therapy may be the sickest ones. but not so sick that they don't make it out. They're going to be the ones that have been on a ventilator for multiple weeks without weaning. Um, I've got a handful of patients right now on my caseload that have been here so long that they're no longer on COVID precautions.
Yeah,
We
we
don't
had
even
that.
wear PPE in their room anymore.
Yep.
So those I think are the patients that we're really going to be seeing. And as one of my mentors, um, who has worked everywhere from Mass General to Emory, but she was in the scrub dress era of original chest PT and ICU early mobility at Mass General, where she would hook up an ambu bag to a patient's ET tube to get them up and walking. That was their portable ventilator. She was like, this is the kind of things that we saw back then, because what
Mm,
was known was bed rest was what cured patients. And we didn't recover and rehabilitate until after the fact. She's like, I
right.
haven't seen this level of immobility and sedation and proning since then,
Yeah,
because we just don't
it's
do it anymore.
crazy.
Yeah. But these patients have been so sick that any weaning trial, any extubation trial was immediately like, oh, nope, tube's going back
Yep.
in, you're going back down. It's just the nature of the beast a little bit, and it's very bizarre having all of the patients across a huge ICU all have the same diagnosis. It
Yeah.
is it is sci-fi level stuff. So that's what we're looking at. Where do they go? Their level of burden on their caregiver, um, anything from assistive device use, gait distance. I mean, you name it, we're pulling it and we're going to see what comes out of it. So
That's awesome, and I think, like, we're actually doing something more similar to that too, where we're doing the outcome measures. So with all of our COVID patients, we're doing, if they are able to perform 30-second sit to stand and a 2-minute step test, and, taking into consideration the oxygen, if they still need assistance while performing these tests, like how long it took to complete them, it's like heart rate, blood pressure, RPE, all that stuff. And I think it's crazy to think that something as simple as timing someone doing sit to stands for 30 seconds could be so debilitating. And,
yes.
that they're so week, I mean, I fought and fought and fought for one patient that I had in the spring who was one of our original COVIDs. He ended up being there for 85 days. And I was like, get this man into inpatient rehab because he could not. We were spending like almost an hour with him every single day. And like in the acute care realm, that's not heard of at all.
Unheard of. Yes.
And the fact that we were still doing this and we still couldn't even like, I think by the very, very end, we just started getting him to, like, hold himself up sitting at the edge of the bed. And
It's unbelievable. I mean,
there's
really
some
how sick and
patients
debilitated they get.
exactly. And there's some patients who I had that were like that at start, but then they bounce back so quickly. And then there's this guy who's like, he could not bounce back for the life of him. We were like, "What more can we do for you?" Um,
Yes.
it's
And
just
we've
crazy.
had like the sequelae of COVID too. So not just like the ICU immobility, ICU acquired weakness, PICS picture, but also we've really seen a lot of that hypercoagulability part of COVID. So we've had tons of stroke. I mean, tons of stroke because of COVID. Tons of vascular issues because of COVID. Lots of, luckily not like limb amputations, but vascular like reconstruction essentially. I've had a couple of spinal cord infarcts. So where this person now looks like a partial spinal cord injury. And then a handful of brain injuries from like agnoxic brain injury. So I mean, if the laying in bed for 2 weeks doesn't get you, something else will. It seems like you just can't win.
Yep.
And you're not even in the ICU. Like, so you're seeing these people like down the road when they're sitting on the floor, just waiting to go
We
somewhere.
essentially became mini, like, step down units, like, not fully acute, but not fully ICU because our ICUs were so overwhelmed, and there's, like, where are we supposed to keep putting these patients? I mean, they were opening up units that technically, like, have been closed for construction or because we have a new tower now, we don't need them anymore,
We
and,
had
like, same
to.
thing.
It's just a disaster. I mean, it really is just heartbreaking.
Yeah.
Every day.
Yeah, and I know it's like and thank you for being on the front lines, and I know that, like, it's not easy, by any means whatsoever, and, there's a vaccine coming and, hopefully people continue to be more responsible, wear masks, socially distance. Holidays are coming up, so try not to gather with grandma and grandpa and do it virtually through Zoom. I know it's tough, we all wanna see each other and hug each other, but I promise you will thank yourself. later. I want to start wrapping up. So, any final tips for students that you have that either want to do residency or acute care or even research?
I mean, just dive into where your interests are. I mean, truly, if you find something that you love or are passionate about or really excited about, dive in. Reach out to people that do it. Reach out to people that have done it, have experience in it in any realm, and just find out more and just keep digging into those curiosities because that's really what's going to lead you to where I think your heart lies. I think that PT students a lot of my classmates, me included, kind of pigeonholed ourselves into where we thought that we wanted to practice. And I've even now had, um, now they've become coworkers because they've left the outpatient realm and have come to acute care because we're awesome. And they just, you find ways that you love what you do. But I think instead of thinking like, okay, I love this neuro class, so I'm going to love working in outpatient neuro. Think about what you love about patients. What do you love about people? What do you love about your life? Find a way that you can have a work life balance. I judge myself daily on my inability to do that, but it's a work in progress.
Practice.
And yeah,
Exactly.
and I think it's just you got to find a way to have a life, love what you do, and not go crazy. And that's kind of the bottom line. I think that's true for
Love it.
students pre PT all the way through like practicing clinicians,
Absolutely.
myself included.
Where can people find you if they want to slide into your DMs, contact you with any questions, comments?
Yes. So I'm at the Acute Care PT on Twitter and Instagram. And then the acutecarept.com is newly up and running. And it's got some blog posts and some resources. Please reach out. And and the acutecarept@gmail.com.
I think we're going to have to do a part two because I feel like we have so much to talk about. So, possibly to be continued. Stay tuned for more. You guys heard it here. This is Dr. Katelyn Corridon, the acute care PT. But thanks for joining, and we will talk soon.
Yep. Thanks for having me.
Thank you for listening to this episode of the All Things Physical Therapy podcast. Make sure to leave a review and subscribe to stay updated on new episodes. You can find more episodes like these on Apple Podcasts and Spotify. And to stay up to date, follow dpt.stuff on Instagram or go to www.dptstuff.com.